I am really pleased to introduce one of my personal mentors in our next session around trauma-informed care. I think it's a great topic to be situated today as we outlined a couple of different disparities focused, inequities focused talks today around, housing and criminality and race. So this talk gives us some solutions to address some of what our patients might be coming to us with and clearly define some of the trauma and burden and weight that our patients might be encountering just as members of society. So in this talk, I want to introduce Dr. Brent Sugimoto. Dr. Brent K. Sugimoto is a family physician and HIV specialist who is currently president of QVMD Health in Emeryville, California, a primary care practice. He is also chief medical officer of Decoded Health, a technology startup with the goal of solving the quadruple aim in healthcare. Brent has been a leader at the intersection of health disparities and trauma-informed care. Brent has given presentations and authored continuing medical education on ACEs and trauma-informed care. And don't worry if you don't know what that is, we'll define it today. His work in this area includes service on the California Surgeon General's Trauma-Informed Care Primary Care Implementation Advisory Committee, a group that focuses on reducing the impact of adverse childhood experiences, or ACEs, and the Expert Advisory Panel for the Family Medicine Initiative on Trauma-Informed Care, or FIT, which forms the strategy and educates California family physician on ACEs and trauma-informed care, a course that I was fortunate to participate in. Brent earned his Master of Science in Health and Medical Sciences at the UC Berkeley UCSF Joint Medical Program, a 5-year curriculum that awards a master's and medical degree to graduates. He completed his medical degree at the University of California, San Francisco, and his family medicine residency training at Contra Costa Regional Medical Center, where he was chief family resident in 2012 and 2013. He currently resides in Richmond, California with his husband and 2 children. He enjoys running, ukulele, and most recently perfecting his cake decorating skills for his girls' birthdays. Welcome, Dr. Brent.
Great. Thanks so much, Dr. Butler. And thank you so much, everyone, for having me, especially to Dr. Butler for inviting me here today. I'm very excited to be here and to talk to you about a subject that is very near and dear to my heart. And I guess, Kelly, I can share my screen here. Okay, let me see if I can work the technology. Here we go. All right, hopefully that is, can you guys see my screen?
Yes, we can.
Cool. So the title of my talk, I named Interrupting Trauma, and it's because I think whether we know it or not, trauma is often in the room with us, between us and our patients. And it is a hugely impactful force, both in that it interrupts our patients' abilities to conduct their own lives, but it also interrupts the relationship that we have with our own patients and our ability to form therapeutic alliances with them, to have a collaborative relationship. And so being able to address this with our patients is actually key, I think, to help actually advance that relationship that we have with our patients and to be able to have a more productive relationship with them. So this is going to be just kind of a teaser talk, hopefully to get you interested in this and to convince you guys that this is something that should be in every physician's practice, no matter what specialty you're in, whether you're in family medicine, emergency medicine, whether you're doing hospital-based medicine or you're a surgeon. You know, anyone who is taking care of a patient can actually become a better doctor by becoming trauma-informed. So really, disclosures, nothing really to disclose here today, but to go over the course objectives. So first, to grasp the public health impact of trauma and toxic stress. And this is, as I intimated before, very profound within our society, to understand how toxic stress physiology affects the health of patients, and to help understand why this is such an important issue for health in our country. To appreciate how trauma-informed care is important in any practice setting, and hopefully to help you begin to conceptualize how to incorporate trauma-informed care into your own practice of medicine. So first, we're going to start out with, and there we go. Excuse me. We're going to start out with the impact of trauma-informed, the impact of trauma and toxic stress. And so, I'm going to start with a definition of trauma. And this is the definition as given by SAMHSA, the Substance Abuse and Mental Health Services Administration. They define trauma as trauma results from an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has, and this is very important, lasting adverse effects on the individual's functioning, whether it be mental, physical, social, emotional, or spiritual well-being. And I just kind of want you guys to keep that definition in mind and how I think far-reaching that definition is in terms of how trauma affects people. So some key points that I want you to keep in mind is, one, trauma is extremely common. And this is a fact that is going to inform how we practice trauma-informed care. But just as an example, if you take rape, intimate partner violence, or stalking, 1 in 3 women have experienced that, and 1 in 4 men have experienced this in their own lifetimes. Trauma has profound impacts on health, and this I'm going to detail a little bit later. And then finally, trauma is an equity issue in our country, and trauma is actually one of the health disparities in our country. And just to convince you that it is actually one of the root causes of a lot of the health problems that we see in our patients and just public health in general. So I'm going to start actually, Kelly said ACEs without my actually giving a definition of it. And I'm sorry that I did not spell that out before. But adverse childhood experiences are 10 types of adversities or exposure to trauma in 3 different domains of abuse, neglect, and household dysfunction. Abuse including physical, emotional, or sexual abuse, neglect including physical or emotional neglect, and in household dysfunction, and you'll actually see this in the literature now referred to as household challenges, but these include things like mental illness, incarcerated, a relative who's been incarcerated, substance abuse in the household, mother treated violently, now more commonly referred to as intimate partner violence, and then divorce. These are the older terms, now referred more often to as parental separation. And ACEs are a concept that first came about actually not too far from where you guys are in Irvine. There was a Dr. Felitti in San Diego who worked at Kaiser Permanente, and he actually ran an obesity clinic down there in Kaiser. And what he found was that initially he would have a lot of success with his patients, and then suddenly they would either disappear or they would gain weight again. But for whatever reason, he'd always hit this kind of wall with his patients where they would make progress, and then suddenly that progress was lost. And this was extremely frustrating to him, and he was trying to figure out what was it that was driving this. And so he began just kind of combing through the medical records, trying to find a pattern to understand what was going on. And it was actually only when he was interviewing a patient, going through asking all sorts of demographic questions, SES questions, and he meant to ask a patient, how old were you when you were first sexually active? And by mistake asked, how much did you weigh when you were first sexually active? And to this, the patient answered, well, you know, I was normal weight when I was first sexually active. I was 9 years old. And that's when the light bulb first went off for Dr. Felitti, and he understood some sort of dynamic that was going on here. And this is when he had a pretty foundational study done on the patients that were at Kaiser Permanente, where he found that these 10 adversities that you see here, these 10 types of trauma, strongly predicted in a dose response fashion the likelihood that someone would have a bad health outcome. And I'll just underscore that again, in a dose response fashion. So the more of these adversities that you were exposed to as a child, the higher the likelihood that you would actually have not just mental health, poor mental health outcomes, but actually physical, what we consider more like physical medical problems, such as diabetes, heart disease, that were independently associated with exposure to these adversities. So, you'll look at these and you'll say, okay, well, these are very constrained set of traumas. And I totally agree with you. And I think that now we're starting to research additional domains that I think are relevant, very much more relevant for what's going on today. The other 10 are very relevant, but these also, I think, capture the full spectrum of how someone might experience trauma in their life, including things like community violence, experience of discrimination, housing insecurity or homelessness, food insecurity, parent-child separation due to foster care or immigration, a parent or primary caregiver with a serious physical illness or disability, and a parent or primary caregiver who has died. These are domains that have been validated for use in children, but now research is trying to look more into how these are also relevant to adults. And so we might see more of that in the future. But the reason why I'm focusing on this when talking about trauma is that actually adverse childhood experiences have a lifelong impact on people who've been exposed to them. And so these things that people have experienced as children seems to burn something into their physiology and into their brain that lead to these lifelong effects. So nationally, and the adverse childhood experiences are not uncommon. As I mentioned before, trauma is actually, unfortunately, exceedingly common. Nationally, 61% of adults report exposure to at least one ACE. Almost 1 in 6 adults report exposure to at least 4 ACEs. And 4 is actually, if you remember this number, 4 is considered the number where you really start to see the poor outcomes start to take off exponentially. And then I talked about this as being an equity issue. And you'll see that there are a lot of disparities related to ACEs. So women, in terms of gender, women are much more likely to have experienced a high number of ACEs. And Black, Hispanic, and Native Americans report a greater likelihood of exposure to at least 4 ACEs. So whereas nationally, approximately 1 in 6 adults report exposure to at least 4 ACEs, almost 3 in 10 Native Americans report exposure to 4 or more. And as I said before, right, the more ACEs you have, the higher the likelihood you are to have these poor health outcomes. Also looking at the LGBTQ community, there's a greater likelihood of high ACE scores, especially when you look at people who are transgender or gender expansive. The rate of ACE exposure for 4 or more ACEs can be as high as 69 to 70%. Even the exposure of 8 or more ACEs looks like it might be somewhere in the lines of 16 to 17% in the transgender and gender expansive community. And so we'll see more about this because it's not something that has been that well studied. But just something that's very troubling when you look at what's going on in our country, but also seeing how this seems to mirror the other health disparities that we see in populations that have been underserved.
Dr. Sugimoto, I just want to make sure that we're seeing what you intend for us to see. We're stuck on the slide that just says the impact of trauma and toxic stress.
So it's not advancing for you?
It looks like it's not. And so I wanted to make sure that we could catch up to you because everything you're saying makes sense. We haven't had any questions dropped in the chat, but
so sorry.
that's okay.
Yeah, let's see. Technology. Let's see if I can do a new share. I apologize, guys. Hopefully what I'm saying makes sense without the visual. And moment. Let's escape here. And if that doesn't work, what I can do, can you guys see my screen now?
Yes, we can.
It says adverse childhood experiences.
Mhm.
Yes.
Okay, cool, thank you. So what I might do is just keep it like this. And then hide that just to make it a little bit bigger. Okay, so hopefully you guys can see that better.
Yep.
Just to point out and to bring it to relevance to our own state, what's going on in California pretty much impacts, pretty much mirrors what's going on in the rest of the country. Roughly about the same number of Californians or percentage of Californians have the same exposure to ACEs. About 1 in 6 Californians has experienced 4 or more ACEs. But one thing, this was studied actually by our current Surgeon General, Dr. Nadine Burke-Harris in California. You'll look at the actual economic impact and the health impact that ACEs have in our state. So looking at disability adjusted life years, there are approximately 434,000 dailies, costing us at least $102 billion in 2013. And this translates, and when you look at excess healthcare expenses related to ACEs, she calculated that out to being about $589 per Californian per year, related to how ACEs impact, both economically in terms of dailies as well as healthcare costs. And so this is actually a very significant impact, right? And then the other thing I think just bringing it into what's going on today, and I think 2 big things that make it worrisome that the impact of ACEs are actually going to be greater because of what's happened in now the last, almost we're entering our 2nd year of this, but one is COVID. And then the other, what has been going on, I think, with our racial reckoning. So, some of the worry is, the impact of COVID, both just from the trauma of dealing with the pandemic, but also the economic impact that this has had on families. And so the huge rates of unemployment, we've seen rates of unemployment that haven't been seen since the last Great Recession, back in the early 90s, seeing signs that there have been increasing amounts of hunger. And then in terms of the trauma that's been coming from, police violence, and just dealing with the impacts of racism of our country, have raised these concerns for how this is going to impact families and how it's going to impact children living in those families. So we don't have a lot of direct evidence, but there is some concern that some things are going on. So if you look at, this is a report of overdoses. And actually these data are actually a little bit old. I think we're getting data that are showing that this might be a little bit higher. But back in June of 2020, 61% of US counties were reporting an increase in overdoses. More troubling or equally troubling was this was in the United Kingdom, just in 1 month, in the first month of the pandemic, when they went into shutdown, they saw an almost 1,500% increase in abusive head trauma in children, just in that month alone, after we went into lockdown. And so just using that as indicators of what might be happening to families, right, dealing with the trauma of COVID. And then just to explore a little bit, that racism is actually a source of toxic stress. I think we know this intuitively, but people are actually measuring this with respect to adverse childhood experiences. We see that disparities with ACEs among racial and ethnic groups may be independently explained, in part by race and ethnicity alone. I think some people may have tried to explain this as being related purely to socioeconomic status, but actually in a study done by Slopin et al., and this is actually, I have the reference there on the page, they found that actually when you looked at ACEs among different ethnic groups and you started to stratify by SES, the disparities for ACEs actually increased with higher SES. And what the authors concluded was that this could only be explained by basically racism, right? That what this was only explained by race alone. And one way this was explained was by actually seemed to validate an earlier hypothesis expounded by Melissa Farmer in 2005. She called this the diminishing returns hypothesis. So that as different racial groups that have historically been marginalized or excluded within our country achieved higher levels of income, there was this plateau where even as they got wealthier, the benefit that they received from this seemed to level off at a lower level than it did for the majority white population, and what she called diminishing returns. And it seems that this may also occur in terms of like becoming wealthier actually does not diminish your risk of actually experiencing ACEs in your lifetime. So going further into this research, and this is actually, you'll see this reference here is just from 2021. It's pretty recent that people are starting to look at racism as a way of explaining what's happening with ACEs. But Shankoff, who's done a lot of research with this on this, states that the conventional designation of race or ethnicity as a risk factor for disparities in health outcomes diverts critical attention away from systemic racism, other structural iniquities, and their deep historical roots as pernicious influences on the intergenerational transmission of stress-related disease. And I think that is a spot-on summary of what is going on here. And so I've talked a little bit about how ACEs are very prevalent, and I've implied that they do have an effect on your health. I want to talk a little bit more about that. And so toxic stress or trauma and adverse child experiences actually have a causal pathway along the way to poor health outcomes. And so some sort of trauma or toxic sort of trauma, especially when it is very intense or chronic, can actually lead to poor health outcomes, both in children and adults. And actually, there's a physiologic pathway for it. So some sort of adversity that you experience actually causes all sorts of physiologic changes, all the way from how your brain reacts to it, to your endocrine system, even to epigenetic changes that happen as a result of toxic stress. And so you'll see that there's a whole host of responses that happen when someone is exposed to some sort of toxic stress. And so this can include continuous activation of the autonomic nervous system, which can cause, as you know, as you learn in medical school, cardiovascular changes, right? Potentially risks for cardiovascular disease, as well as how this activates the brain. And we see that this is seen on MRIs in terms of things like enlargement of the amygdala, right? Where emotions are controlled, where the fear response is controlled, to shrinking of the hippocampus. So actually decreasing the ability to encode memories, to remember things, as well as shrinking of the frontal lobe, where a lot of the executive function happens and where we have regulation of our emotions. That stress actually can cause a chronic elevation of activation of our hypothalamic pituitary adrenal axis, which causes an excess increase in cortisol. And this causes a whole bunch of things, as you guys may remember from studying things like Cushing's disease, right? Too much cortisol and you get too much blood sugar. You get all sorts of physiologic changes, both to like fatty liver and all sorts of immune dysregulation that comes from having too much cortisol. it also includes things like increases. You can actually take children who've been exposed to a lot of toxic stress, and you'll actually measure high amounts of CRP that actually can be reversed if they are provided with kind of supportive influences. So like an always available adult who can provide nurturing care can actually decrease CRP in children. So a lots of mounting amounts of evidence that stress actually intimately affects how the body functions and impacts actually the health outcomes that you can see. And so this is just more explanation of that, how stress can cause all sorts of changes to our physiologic pathways. And so some of the things that we see are the types of effects that you see are things like increases in heart disease. And just to mention that ACEs are associated with 9 out of the 10 leading causes of death in our country. And so you'll see here the magnitude of those effects. So this is independent association. So independent of any other factors such as smoking or mental health, ACEs themselves seem to be independently associated with things like heart disease, with cancer, with lower respiratory disease, kidney disease, diabetes, and dementia. So very interesting and troubling data. And this is a more kind of complete list of all the conditions that ACEs have been independently associated with in adults. And then here we also see in children. Even the things that we think of as like maybe completely unrelated to toxic stress, like eczema itself is actually an ACE-associated condition. So now that we've seen like all the different ways that trauma can affect the body, right? What do we do about this for our patients? And this is the million-dollar question. And what I will preface this with is that this is actually a relatively new field of study, and there's not a lot of good evidence behind it. And so for those of you, if you start to incorporate this into your practice as you go further into your career in medicine, you're actually going to be on the leading edge of medicine. As the evidence mounts, we're going to hopefully find more and more ways that we can help patients who've had a history of trauma, and learn more as it goes as we go along. But just know that right now, a lot of what we do is not evidence-based, unfortunately, and hopefully that will get better as we go along. But one way to deal with this is one thing we call trauma-informed care. And if any of you have been exposed to this in any of your rotations, trauma-informed care is an approach to care that promotes a culture of safety and empowerment to foster recovery and healing through safe and collaborative relationships. And this is one thing I just want to underscore here is through safe and collaborative relationships. And so one is making your patients feel like they're safe. And another is collaborative also implies that there's consent going on. And why these two things are important is for people who've had a history of trauma, they often feel like they don't have don't have this very developed sense of safety. And they also don't have this very developed sense of control in their lives. And so by helping them feel safe, and by being collaborative with them, by always getting their consent for whatever you do, you actually help them establish a sense of control in their relationship with you. So trauma-informed care then, seeks to reestablish the safety and control so that patients can engage in their own care. Now, one thing I want to say that's not on the slide, I think that the term trauma-informed care can seem kind of overwhelming, I think, to any physician who is first exposed to it, right? Like, how am I supposed to treat someone's trauma? And just to point out that that is not the case, right? We're not actually trying to treat their trauma, but we're trying to develop approaches so that when we engage patients who've had a history of trauma, that we're actually engaging them in the way that we can have a better caring relationship with them. So it's not trying to cure their trauma, but it's a way of engagement. It's a method of engagement with your patients so that you can have a better therapeutic relationship with them. And so this is just talking about the principles in trauma-informed care. And I've talked a little bit about this. You'll see on the right, there is this little diagram, and this is actually developed by Dr. Eddie Mockner, who runs a trauma-informed women's clinic for women living with HIV in San Francisco. And he developed this because he was finding that a lot of his patients did have very significant histories of trauma in their life that influenced their contracting HIV, and found that he needed an approach that allowed them to engage them better. And so he had these kind of 5 principles here. One was a foundation in trauma-informed values, as we discussed before. That was in an environment that was calm, safe, and empowering for their patients, right? So being in a safe environment allowed the patients to begin to feel safe. To have a sense, to have inquiry with your patients about past trauma, but also allowing the patients to have control about how much they actually want to disclose to them, right? You don't want to re-traumatize a patient by having them disclose all the trauma that they went through if they're not ready. And then also, extremely important is whenever someone discloses a history of trauma to you, then it is incumbent on us as their care providers to respond to that disclosure. You know, I kind of think of it as like, if I told my best friend that my parent died and they just kind of looked at me and then moved on, right? They probably wouldn't be my friend for much longer. And I think it's kind of the same for our patients, right? If our patients just told us about a horrific history of sexual or physical abuse that they had in their household, and then you start to talk to them about their the amount of carbs that they're eating for their diabetes, right? They're not going to feel very trusting of you. And so I think there's a very good, it's a very apt analogy there. And then finally, educating patients about the impact of trauma, because by having patients understand that this pattern, right? Patients who've had a history of trauma often have these patterns in their lives where this lack of sense of control and safety lead to kind of these recurring re-traumatizations and feeling out of control of their life. And by educating patients that actually this is something that is not their fault, this is something that has happened to them, can actually reestablish some sense of control and actually be empowering for a lot of patients. So how do we put this into practice? And one is, as I mentioned before, is whatever you do with your patient, always get consent for it. So whether that be asking them about their sexual history, for example, asking them if that's okay. If you're going to screen them for trauma, getting their permission for doing so. Another important time to do this is during the physical exam. So if you think about doing pap smears on your patients or doing any kind of pelvic exam on either your male or female patients, is making sure that that's okay with them and being sensitive to the fact that they might not be comfortable with this. Reflective listening and empathy. And so especially when someone tells you something that is very traumatic, listening to them non-judgmentally and reflecting in ways that let them know that you care. So saying things like, this is not your fault. Communication is a very important thing, and this is a very challenging thing to do in practice, right? Especially when we are so hurried as physicians. I think we're trying to be as efficient as possible, but knowing that this can actually impact how our patients perceive us. So like if you are trying to talk to your patient and chart at the same time looking at the computer screen, right? That lack of eye contact can actually diminish that sense of trust. When you're examining a patient and they're lying on the exam bed and you're standing over them, talking to them, then that actually is setting up this power differential where patients actually feel powerless, and it can make them feel less safe. And then other things to consider are the environment. And these are things that we often don't have control over, but things that maybe we can, maybe in our own exam rooms, or maybe something that we can do as part of our quality improvement project. So things like, what does the clinic look like? So does your clinic or your practice have a space where all the chairs are all crammed together and everyone is kind of like sardines in the waiting room, right? Where it's kind of claustrophobic. Do the educational materials in the space for patients, do they actually have pictures of patients that look like them, right? If you are serving primarily underrepresented minorities and everyone on the posters in the room are white, right? What are the patients going to conclude about whether or not you're going to be able to take care of their needs, right? Same thing with, what does the staff look like? Does the staff kind of look like the patient, the community that the clinic or healthcare setting is that is caring for the community? I think this is one of the huge issues, I think, for medicine is the fact that right, underrepresented minorities in medicine are highly underrepresented. And so in terms of being trauma informed, this is a challenge. But I think being aware of this dynamic can be helpful in terms of helping our patients feel safer and better cared for. And then finally, safety is a big thing. And so this, I think there are a lot of ways that we can't control this in our built environment. You know, some trauma-informed clinics will try and make sure that the entire front of the clinic or the care space has like glass windows and glass doors so that it feels more open, and that the doors are controlled so that they don't slam shut and create a lot of noise. That the waiting areas have maybe soothing music, or they have things like plants or lighting that makes it feel like a safer space. To even making sure that one clinic I went to, they took care to make sure that there were no sharp corners on any of the countertops, that everything looked rounded, because to some patients that was actually triggering to see things that were sharp. But I think things that we do have control over is what happens in the exam space when we're actually with our patients. And so one of the important places to this is the physical exam. And so just being aware of places where patients may feel unsafe. So one example I like to give is like when you do the thyroid exam, right? How do you do that? Well, the way I was trained was you come up from behind the patient and then you put your hands around their neck to feel their thyroid. Well, you know, if you think about a patient who has ever been assaulted, who's ever suffered intimate partner violence, this could actually be very triggering for them, right? Same thing when you think about things very intimate exams like pelvic exams. These can also be things that are very triggering. And so this is where communication is extremely important. Talking with your patient about you know, giving them a sense of control of when you do these things. First, getting their permission to do these parts of the exam, right? Not open your mouth, but could you open your mouth for me? You know, if it's the pelvic exam, asking them, right, let me know if you need me to stop at any moment. Like giving them a sense that they control the entire process is extremely important. And then finally, I think an important principle in trauma-informed care is universal precautions. And so I first learned universal precautions, and I'm sure you guys did too, in terms of infection risk, right? And this all started with HIV, because in the very well, we still can't, but with HIV, you could not tell who was living with HIV and who wasn't. And to avoid transmission of HIV, both among patients and to staff, was adopting what's universal precautions. So doing your workflows in the exact same way so that you minimized transmission risk of an infectious disease. Well, with trauma, you can't look at your patients and know which of your patients have experienced trauma, right? And so by exercising universal precautions and treating every patient as if they may have had a history of trauma, you actually can avoid re-traumatization of those patients. And so universal precautions is a very important principle. And, where I think having a trauma-informed approach is very helpful for us as clinicians is providing us a different lens through which to look at our patients. And so if you've ever had, I don't know if you've ever had this with your attending, right? Or if you've had this in patient care yourself, where you've had a patient who's been actually pretty frustrating, right? Maybe they aren't taking their medications. Maybe they always no-show for their visits. Maybe that they just have trouble with relapsing with some sort of substance that they're taking. And I think there is this reflex sometimes among some of us to think, right, why does the patient keep doing this? What is wrong with this patient? But a trauma-informed approach actually shifts that focus and I think provides a different lens to say not what is wrong with this patient, but what happened to this patient. And when you can shift your perspective in that way, that can actually change your interaction with the patient so that you can actually have more productive interactions with them. So I'd like to spend this last part. This is actually based on a real case of a patient that I cared for. And I would like this hopefully to be interactive and to get your thoughts on this. So please feel free to chime in whenever you might. But this is Corey, and he's a 23-year-old patient who was living with HIV and clinically has a diagnosis of AIDS based on a CD4 nadir of 182. He has also had profound episodes of depression, and during these times, he will be lost to follow-up and will stop taking his HIV medications. So today when we meet him, he's in good spirits. Corey is extremely intelligent. He just learned that his organization was awarded a $5 million grant for a program that he designed to serve Oakland's homeless youth. And this is very meaningful to Corey because he himself was homeless when he moved to the Bay Area at an age of 14. You notice that Corey is sitting uncomfortably, however, and you ask him about that. And he admits that he has been having rectal pain lately, but he has been afraid to look down there. So just based on this description, are there any indications of trauma that you learned, or what are the indications of trauma that you learned from his history? And
chat box is open. If folks want to drop in the chat box, you can also message either me or Dr. Sugimoto privately, or if you just want to unmute yourself and chime in here, then you're absolutely welcome to. There'll be a few kind of discussion points around this case and others.
let me see if my chat comes on. Come on, guys, don't be shy.
Well, I can kick us off in saying that, Corey admitted that he was homeless, and Joanna agrees. It's part of his history and it's part of his trauma. I think we heard from our session today in correctional health how homelessness and being unfamiliarly housed comes with a lot of stress. So absolutely, Julie offered the history of depression. Corey might also encounter stigma or stereotyping as a result of his diagnosis of HIV and later AIDS. I think it's no secret that there is an entire world and burden of stigma around HIV. Joanna specifically targeted the fact that he was homeless at a young age, which might indicate that he had a lack of a family network or role models, which in our actual ACEs survey, The absence of family members is one of the things that are asked if you experienced that absence before the age of 18. So absolutely, Joanna.
These are excellent pickups, guys. And exactly, right? Like the fact that he was homeless and moved here from somewhere at the age of 14 shows a lot of, I think, lack of support. And unfortunately, right, Corey is, as a young gay man, and actually the picture shows a Black man here. Corey actually is African American. And one of the sad realities in this country is that the lifetime risk of becoming HIV positive for a Black man in this country is 1 in 2 if you're a man who has sex with men, right? And that's staggering, right? 50% of Black gay men are going to become HIV positive in their lifetime. And so just pointing to that kind of the stigma, but also, right, what is going here in terms of why is this happening to Black men, and just considering like how trauma is on the causal pathway to Corey becoming HIV positive.
And it's for some unavoidable factors too. Melody added just facing racism in general could be a traumatic part of his history as a Black man. And you just pointed out that point as well.
Excellent, guys. You guys are rock stars. So what would be your next steps for Corey? Like, so we identify, right, his problem today is that he's having rectal pain. And probably a good idea for us to take a look at that, right? But how would we do that in a trauma-informed way?
Coming back to some of those steps that Dr. Brent outlined earlier for us in the physical exam and how we approach taking a history. This might be a little advanced for our pre-medical students on the call, but for our medical students especially, how could we approach his exam a little bit more thoughtfully? Melody first says, ask for permission first before even doing the physical exam. Absolutely, Melody.
Perfect. Yeah, nice. What about how the exam is conducted? How would you, if you were his doctor, how would you conduct that exam, right?
If I could just be a student for a second in your class, Dr. Sugimoto, then I would add also just asking what he would like for us to do instead of saying, can I do this? For someone who has a history of dipping in and out of care, even just asking, what do you feel comfortable for me doing for you today? Or how can I help you today, before it's, can I do a rectal exam? Might be a first step.
Dr. Butler, you're getting an A+ today, right? Like, I think in terms of helping patients feel like they are an equal partner in this, is allowing them to set the agenda. What is important to them, right? Not what's important to us. We do have things that we worry about, right, when we're caring for our patients, that we want to make sure that they're healthy. But first, we need to know what it is they want help with, right?
Melody added a little sprinkling there, then talking through individual parts of the exam and letting their patient request to stop at any time. So you could prime it, say, if at any point you feel comfortable, just let me know and I'll stop, right? Nisha said, asking for permission and then setting the comfort level, like the patient has say in the care. Absolutely. We talked about environment and how it's important to set the environment adequately. And sometimes that's by the words that you say. That might mean that a certain flag is hanging in your waiting room, that Corey was addressed by his correct pronouns before he came into your office, etc. All of that matters in terms of setting the comfort level. Absolutely, Nisha.
You guys are making me so happy. I don't think you need me here today. So you asked Corey if you can do an examination and explain why this is important. Corey appears nervous, but he agrees. You empathize with Corey that these types of exams are not comfortable and that most people would feel some anxiety about it. You ask Corey what would make him feel safe in this situation, but he wants to make sure he is minimally unclothed and is afraid of pain. You reassure him that he will have full control and can stop the exam at any time. You return to the room with the chaperone and Corey is lying on his side on the bed with the drape, his back to you. You walk around to the front to describe the steps of the exam and what you're going to do, and you explain that unless he prefers you do not, you will explain what you are doing at each step. The exam goes smoothly, but you discover extensive anal condyloma or anal warts, and you worry about anal cancer. You explain your findings and recommend high resolution anoscopy with a colleague you trust. Corey agrees, and you make the referral. So I think a lot of what we talked about the last slide, right? A lot of what happened here, but I don't, do you guys think this was a perfect interaction? And what might you do differently in this interaction? And I think Dr. Butler, you said some of the things, right? Like allowing the patient to set their own agenda about what they want to happen, I think was an important one. Anything else that people thought, or what was their thoughts about this interaction here?
I think a really important step here is towards the end in our last paragraph, explaining what a condyloma is, means, what the risks and benefits are associated with potential endoscopy. Instead of just saying this is what we're going to do next, just making sure that patients understand what that next step is for. I know I've encountered a lot of patients who will come to me on a list of medications, who will have a whole barrage of things done to them, and I ask them, "Do you know why?" And they just don't, which is wild to me. So I think a part of being trauma informed is to keep the patient informed. That's how we ensure justice, right?
And I think that's extremely important, right? Because I think when someone's in a space where, especially, right, if we're performing universal precautions, right, and but someone is becoming re-traumatized in some way, it becomes extremely hard for them to communicate and to listen, right, to hear what you're saying. And so it becomes really incumbent on us to make sure that we are still having that two-way communication. And so sometimes that can mean pausing, right? Like really keying in what's happening to your patient. Like sometimes you might see them gripping the sides of their chair like this, or they could have this kind of dead look in their eyes. Maybe you might even notice some hyperventilation happening or something happening that shows that they're extremely tense. And you might need to like stop the interaction. And sometimes it's even a matter of grounding, right? Like, hey, I'm right here, like, right? Or it's okay, you are in, reminding them of where they are. You're in the clinic right now, right? You're with me, you're safe. Sometimes these things are necessary, especially with patients who've had an extensive history of trauma. And so, you know, with Corey, we already have a lot of red flags with, and just being attuned to these things to see if these are things that you need to keep in mind. So Corey no-shows to 3 successively scheduled high-resolution anoscopy exams and will not return your calls. He misses his next HIV appointment with you and you don't see him for 6 months. He eventually returns and he says the rectal pain has gotten worse. And although you are worried about the condyloma, you forego another exam so that you too can discuss Corey's concerns. So this gets to Dr. Butler's talking about, right, what is important to Corey. And Corey actually tells you that he ran away from his grandmother's while his mother was in prison for drug possession when he grew up in the South, and he ran to the Bay Area where he thought it might be easier to be gay. But without any support network here, he actually relied on sex work to survive while living on the streets. And at that time, he had been raped by one of his Johns and now he gets panicky with any anal contact. So now we understand, right? Like first he has this rectal pain, and then right, I asked to do a rectal exam, which was the most traumatizing thing to him. And then we recommend that he goes to someone else he doesn't even know to have another rectal exam, right? And so just thinking about taking this from his perspective through his lens, what this might feel like to him. So you empathize, telling Corey this is not his fault. And you tell Corey you think this is a reasonable reaction to what happened to him. You also take an opportunity to educate Corey about the effects of trauma. And Corey seems to feel a little bit better. So what did you learn about Corey's childhood history of trauma? Can we like maybe sum them up, right? What happened? What's been going on with him?
And this is also the beauty of primary care, right? That we could see him for more than one visit, even if there was a lapse in care, at least we get to see him again and it be the same person. I would argue that Corey might have even felt more comfortable disclosing some of his history because he's interacted with you already. Subtle plug for family medicine. So if anyone has thoughts about what we've learned that's new about Corey, Melody adds there's ACEs present, one of them being a family member in prison during childhood. Absolutely. What other ACEs do we see here? If we can think back to Dr. Sugimoto's earlier highlighting of the individual factors, Joanna mentioned a history of sexual abuse and trauma. Absolutely. Having been raped by one of his customers, that's what we mean by John, someone that was paying for sex work. Absolutely, Joanna. Yes. And though an ACE is typically associated with childhood, I think acknowledging more contemporary trauma is absolutely necessary. So yes.
Right. And then I think this might not be a contemporary ACE, right? A traditional ACE, but the fact that he ran away from the South, right, at the age of 14. This is a true story, actually. A lot of this is based on fact, unfortunately, but ran all the way from the South, the deep South, to the Bay Area to escape at the age of 14, right? So there was something else going on there, right? And at least in his upbringing. Excellent, guys. You guys are rock stars. So you call your surgical colleague, who actually comes to your clinic to introduce himself to Corey so that they can establish a relationship. And although usually done in an exam room, after talking, right, about Corey's concerns, they agree to arrange for an exam under anesthesia, which Corey says he feels safe to do in this situation. Fortunately, the biopsies are negative and Corey recovers well after fulguration for his condyloma. So just meaning kind of removing the condyloma. And he says he feels good about it. Corey tells you that this is the first time he has told anyone about a history of assault and he has carried a lot of shame over it. He also says knowing that his is a common reaction to trauma makes him feel better knowing somehow that this isn't his fault. And while he has resisted in the past, Corey agrees to referral to mental health and is open to trying out one of the support groups for young men living with HIV. And I know we just have a couple minutes left, so I want to leave some time for questions. But just some things I want to highlight here is that a lot of people with trauma do have a lot of shame over it, and it makes it hard for them to disclose to anyone. And so I think the way we respond to that is extremely important, but also that by educating people, right, that actually can help remove a lot of the shame that they have, especially to know that a lot of what's happening in their lives, a lot of things that feel out of control in their lives is actually due to this trauma, can be very empowering and can help them engage in their care. And so just keeping these principles in mind, I think it's not that, again, we're not treating the trauma for the patient, but we're trying to engage with our patients in a way so that we can engage with each other, so we can have a productive relationship. And hopefully this is made the idea of trauma-informed care, if you had some trepidations about it, feel a little more approachable and maybe a little less scary. But thank you so much. And does anyone have any other questions?
Great. Well, thank you, Dr. Sugimoto. I knew you'd be the person for the job in this discussion, bringing in a real humility to this discussion and acknowledging that humility is kind of the base of being trauma-informed. I want us to understand where this fits in the larger conversation around being politically minded or being activists or advocates. I think that truly grounded advocacy work is trauma informed. It means that you're informed about the trauma that either a community, cause, person you are representing in a certain fight has experienced and leverage that knowledge in your action. That's exactly what we want to put into clinical practice. That's exactly what we want to put into our work outside of the exam room. This framework in terms of how to approach people is not necessarily unique to just, the person with the glaringly obvious screaming elements of trauma like Corey might have had. They can be in more subtle interactions too. It certainly fits in with our trans and gender non-binary patients that we encountered in our trans affirming care talk last week with Britt Cervantes. Just know that this is a framework for how we can really approach life. And I dropped in the chat, this is really a lifestyle, that we can move through all the interactions we have in advocacy, in patient care, in being trauma informed. So I want us to assume this. We don't expect you to leave an expert, but we do expect you to leave knowledgeable. So thank you for being with us, Brent.
I just want to say, Dr. Butler, that was so beautifully said, right? Because I think trauma-informed care is really an approach in empathy. And I think that I also think that advocacy starts with its roots in empathy, right, for our patients, because that's what drives us to actually go out there and advocate for them, to know what their lived experience is like, and to feel that we need to change it. So I'm so glad that you guys are going to take up this fight and join us in medicine to help lead the charge for changing how we do medicine and changing healthcare. And thank you so much for having me. It's been a real pleasure to be here.